Welcome, folks. I do want to let you know that we are recording this and we're excited about the opportunity that digital technologies give us to be able to be flexible for when people can be here, but also when they can catch this on our podcast list online or our YouTube channel and those various places. We hope that you may share this with folks so you know this is information that they would crave, they would need, they would hope to be able to receive, even if they can't be here live. So I'm going to begin with myself as an introduction, and then I will pass around to my panelists. I'm Kevin Ressler. I am the president and CEO for the Alliance for Health Equity in Coatesville, Pennsylvania. We are a place-based organization that focuses on the social determinants of health for the Coatesville and greater Coatesville area. Of course, our work as a result can ripple beyond that in Chester County and even beyond, but the primary focus of our work is in that Coatesville area as a result of our own history coming from the closure of a hospital way back in 2001 that provided us the resources to continue to support the community through grants as well as direct service programs that are in the benefit of our community members, particularly those who have had unfair and undesired and unearned barriers to their opportunity to equitably access resources and opportunities in the community that they live or work or play in. So welcome to all of you who have joined us here. There's a number of folks here. Again, I said this a little bit earlier, but in case you did not happen to log in yet, there is a chat and a Q&A button on your screen. You can use those to engage with us. Please feel free to put your name in there, what organization you are. If you want to put your email contact to be able to connect folks or folks to connect with you related to the things that you participate with, please feel free to do so. I'm going to lead today here a conversation. We call it a panel, but it's really a conversation amongst three wonderful medical professionals here who are helping to drive forward health equitable access for community members and order to make sure that the whole community is a healthier place. Some here are providers, some here are administrators, but we're going to get into that a little bit later. I'm going to go ahead and look at my screen here, and I'm just going to go counterclockwise because I'm in the top right. So I'm going to invite Janet and then Dr. Janet Jacoparo, Dr. Tiffany Cook, and Lisa Jones here to be able to, in that order, introduce yourselves, and then we'll hop back to me. So thank you.
Good morning. So I'm Janet Jacoparo. I'm an internal medicine physician, and I'm the medical director at Community Volunteers in Medicine, which is a free clinic in Westchester with 2 microsites, one of which is in Coatesville, serving uninsured patients whose household income is less than 300% of the federal poverty level. And I appreciate being invited to this panel to talk about my favorite thing with 3 of my favorite people.
Awesome. So good morning, everyone. My name is Dr. Tiffany Cook. I am a pediatrician by training. That is my first love. And I'm also the medical director for DEI Health Equity at Penn Medicine Chester County Hospital. So that's kind of my dual role. Happy to be here. Happy Wednesday.
Good morning, everyone. My name is Elisa Jones. I serve as president and CEO of Union Community Care, which is a federally qualified community health center serving Lancaster, Lebanon, and Chester counties. And my professional background is in public health.
Marvelous. Thank you all. So I want to hop right away, and we're going to start with you, Dr. Jacoparo. Do you want me to just call you Janet through this? Just Janet?
That's fine. I answer to a lot of names, Kevin.
Well, one of the things that I appreciate about CVIM, as I've learned, is that intentionality of being connected with their patients. And so, I know that some places realize that part of that is how you show up formally and how you show up informally and how you make people comfortable and those types of things. I'm curious with that a little bit as a context. Could you discuss some of the challenges of identifying the patient's clients for CVIM in the Coatesville area, both identifying but then also getting them engaged? How do you reach out to folks who are often disengaged from systems for a variety of reasons, many of which are not good? How do you help to re-enfranchise people into systemic healthcare?
That's a great question. We currently have 5,000 patients, and I'll tell you, most of our patients come to us referred by other patients. So it's generally spread through word of mouth in the community. We also get quite a number of patients through hospital discharges from both Paoli Hospital and Chester County Hospital primarily, but also from Christiana Hospital and Einstein Hospital and some other places in the region. So most of our patients find us through word of mouth. We do like to participate in a lot of different health fairs in the community to make sure that we get the word out. We visit some local churches and other faith-based organizations to let people know that we're here. And we try to be ambassadors anywhere we are in the community, all of our staff and volunteers, making sure that the community is aware that we're here and available to them.
Thanks. So, Dr. Cook, let's use that to jump over to you, right? Because she just said that one of the ways that they get referrals is coming from the hospital where you are working, that the Chester County Hospital. What does that relationship look like for you as the traditional provider working with CVIM, who is providing services to the uninsured population?
Yeah, so we rely on, in order for us to kind of maintain and do things in the best way possible and provide high quality care, we do rely on our community stakeholders to do handoffs and transition of care. So ultimately, when there's one like deficit or unbalance in the system, somewhere someone else is going to experience that. So we are, capable of handling those like ER visits and discharges, but ultimately we want to try to prevent them from coming in, right? Ultimately, we want to talk to another provider in regards to where are the gaps, how do they get here, and what steps need to be taken to prevent it. So that's being preventative versus reactive. So we do rely on the outpatient world to do things as best as we can to make sure we're not having our ER overwhelmed, to make sure that people are not being readmitted or admitted who may have not needed it. So missed opportunities. So definitely a need for collaboration, and we depend on each other.
Thanks. And Lisa, the same thing then to you. Sort of how do you fit into this patient mix in the community? How are you finding your partnerships and finding your people? You're going to be, just so the broader audience here knows, we own the Brandywine Center. The Alliance for Health Equity owns the Brandywine Center at 744 East Lincoln, and we have had a provider there for many years. And Union Community Care, starting July 1st, will be taking over that site and becoming the provider for that primary medical and primary dental, which obviously Dr. Tiffany Cook just mentioned is a part of the preventative element there. So how do you fit into this landscape as your organization entering here into Coatesville?
Yeah. So community health centers really are a backbone of primary care. So if we think of it nationally, we are the largest primary care network in the United States. 1 in 10 Americans gets their care at a community health center. So how we fit in the landscape is we fit squarely at the bottom of the safety net, and it is a very strong bottom of the pyramid. So ultimately, what we know is that healthcare is very weird. Right? It is very weird from an economics perspective. It doesn't work the way other things work. And given the political environment, many of us we've been a little bit more educated on economics. So in traditional economics, if you want something, the price goes up. If nobody wants it, the price goes down, right? That's traditional. But that's not healthcare. So if the price of brain surgery went down to $2, do you want brain surgery? No. So healthcare is so interesting because it doesn't work that way. And instead, what we do is that we have a skill set, we have abilities, we have amazing clinicians like Dr. J and Dr. Cook. And what we do is have people who need those services. But our job as community health centers is to make sure to right size what you need, what is affordable, and where's the best place to get it. Because you will get amazing care at an emergency room at Chester County Hospital. You'll get premier care. But is that the best care in terms of price, efficiency, when we look at the community as a whole? So community health centers are here to make sure that you get the best possible care in the way that's also efficient and affordable, because we know that ultimately it is a very complex system and it's a difficult system to manage and it's a very costly system. So we need care that's affordable, and that's really truly, of course, in addition to the free clinics, that's where community health centers really do our best work.
Now, I do want to say, I think you make a good point, Lisa, that there's something about relationships, right? So is it the best place to get a guidance in regards to forming like long-term plans? I think that one of the best things about a medical home is that you do have a provider who can talk to you about your capacity and your ability, your wishes, like what do you see as long-term goals? And you can do that in a safe space. I can say that working in the ER, it's very chaotic. It is very unpredictable. And to have those safe conversations, it wouldn't be the ideal place.
Yeah, my older brother is an ER doctor, and the conversations I have with him, when he starts to talk about the relationships he has with people, that's usually like a yellow flag, at least. Like, why is this person continuing to come back to the point in which they're requesting a particular ER doctor? Like, you don't really want to have that kind of relationship with the ER. And so we're trying to think about ways not to say that the ER isn't good or the ER is bad, right? It's the ER is the wrong place for this part of your healthcare, right? That flips the other way too, right? If someone shows up having a heart attack to primary care doctor, that's the wrong place for you to be showing up in that moment. You should be at the ER. And so even though the system is not directly designed to always work together and function together, the providers, those of you doing the work, understand that value in spite of maybe institutional fracturing, and so are working on the ground. Are there ways in which you, the three of you as persons, or you can think your entities, do have a regular way of touching, or is it just a little bit more happenstance and referral? But how do you think about strategy collaboratively?
Start off saying CVIM was actually born out of a group of Paoli Hospital emergency room physicians who felt like they were seeing a lot of uninsured patients looking for essentially primary care needs in the ER. And that was resulting in a lot of congestion, long wait times, increased cost of care. And really the patients weren't getting what they needed. They were just getting sort of a Band-Aid for what they were asking for, because as Tiffany pointed out, the ER isn't the place where you get preventive care or long-term care for chronic conditions. So CVIM was founded in 1998 for that very reason, and I think we continue to have a very strong relationship with both of our hospital partners, Chester County Hospital and Paoli Hospital, to receive those patients from the ER who either didn't know that we were here and that we could provide services for them, or didn't realize the extent of services that we could provide. And I'll say that my staff and I frequently visit the ERs at both hospital systems to remind them that we're here and available to you anytime. Everyone there has our cell phone numbers, so that if a patient of ours comes into the ER and they're not able to relate their history, their medications, any of the salient information, you can contact us. You can also contact us when you're discharging someone we've never met to ensure a smooth transition of care. We have a social worker here who's dedicated to helping with those hospital discharges, and we have some liaisons at both hospital systems with the case managers to make sure that those transitions of care work well. And I'm looking forward to a similar relationship with Union and Elisa's group when they move into the Brandywine building, because there are people who move in and out of insurance and who move in and out of employment status. And so there may be times when CVIM is the right place for them to get their care, and there may be other times when Union is a better place for them to get their care. And to be able to do those warm handoffs and make sure that nobody sort of falls through the cracks, I think is paramount.
I think having these kind of conversations, I know that in the past, Jan and I have met several times, like on off hours, just to kind of go through what we're seeing, gaps, barriers, just being really transparent and how we can kind of collaborate to make access more readily available and more knowledgeable to the community.
And then, of course, there are kind of also formal mechanisms. So in our case, we do sit on committees of hospital boards, and we welcome members of hospitals and, of course, our free clinic partners to also join our board, because that makes sure that also at the corporate level, there's good integration, and that as we kind of set strategy, we're making sure that we're doing it in collaboration and not in a silo.
So, I remember being a kid and I went to Eastbrook Family Medical Practice, and it was an independent practice. It's now, I believe, part of the Penn system, but it was at the time an independent practice. And going from one doctor to another, even if it was a specialist, was a little bit arduous because, not dissimilar from this bookshelf behind me, there was just files. I remember you'd walk to the patient care room and you'd see this massive library of files, and you knew that, like, I existed somewhere on that shelf. getting those records to another entity was not a seamless and easy transition. Can as you're talking about this, and I'm hearing patient movement, and I'm having like sort of a trauma reflective thinking about that, which is no longer the way things work. How difficult or easy is it for you, say, Janet, you realize someone now has insurance and Union is the better place for them. Are you just sending them there and it's starting all over? Are you able to transfer those records? Obviously, Elisa, right now, you're having a conversation with ChestPen to move records from ChestPen to Union. I'd just be curious to understand from a principle of ease for folks, what burden are you asking them when you say, well, you're going to have to go here now?
Yeah, so I'll say there are some formal mechanisms. So I am courtesy staff, so I don't have admitting privileges or anything along those lines, but I'm courtesy staff in both hospital systems, Mainline Health and Penn. So I'm able to view what's happening with my patients when they're hospitalized in real time and start to plan for their discharge. And I can reach out to the team that's managing that discharge and let them know what services I can provide and how I can help with any bridging. Union Community Care is new. This relationship is new because they haven't moved into the Brandywine building yet, but I have every reason to believe that, we're co-located in the same building, so I don't anticipate any difficulties with that. And I know Elisa's group and CVIM are both trying to look for our next electronic health record system that will work, and I'm very hopeful that those systems will be compatible. The one that we have currently is not compatible with either hospital system. So while I can see their records, they can't see mine, which is why I try to make myself very available to relate patient histories and medications and allergies and all of that salient information.
Thank you.
In our case, we do have a connection with Epic, which is what I believe Penn Medicine uses, and so we are able to see, and they are able to see ours as well. And we are working with the current health center in the Brandywine Center right now to make sure that patients choose. So I always like to reinforce that there's nothing happening behind the scenes. Patients have to choose for their record to be transferred to Union, and if they choose to trust us with it, we'll have it as of day one when we arrive, which is July 1st. If they want to wait and see and come for a visit after July 1st, we would love to see them. And at that point, we would be able to transfer their record over if they decide to become a patient. But I did want to just say, I think records are so important. Like, it is so important for clinicians to have that information. And a record is not all you are. What it says on a piece of paper is not all you are. So our clinicians try to very much ensure that, we are seeing you as a whole person. And if it is the first time the clinician is meeting you, they very well may ask a lot of different questions because they're trying to get to know you. And there is no one piece of paper or one diagnosis that encompasses all the uniqueness that you are.
I wanted to touch on your PTSD, Kevin, about moving between all those different providers and say that when Elisa says that, community health centers are really the backbone of care, I think one of the things we do really well is that patient-centered care and being a medical home, and not just co-location of services, but true integration of services. So that if you're coming to see me for a primary care visit and we can see that you're really struggling with your diabetes diagnosis, I can pull in my diabetes educator to the visit. If you're struggling with some mental health issues or some stressors that are going on in your life that are making it difficult for you to manage your medical conditions or difficult to live as your best self, I can pull in my professional counselor to that visit. So I think hopefully we're eliminating a lot of that. And when sort of the word in the biz is healthcare days. So you'll hear, especially from older people, I go see my primary care and I end up with 4 more referrals and I have to go see all those other people. And then I have to see the counselor on my own through my insurance. So one of the things we do extremely well is coordinate that care. And if it can be within one location, so much the better for patients who are already struggling with transportation and time off of work and trying to meet the needs of their entire family in one location.
Dr. Cook, we just heard a lot of really good things about that medical home. You referenced it earlier. Where do you fit the hospital system? Isn't just the ER. There's a variety of other things. Where do you fit within this context of integrated, sort of fully integrated care? Are there resources that these folks don't have that you can sort of provide, and how does all of that work together when you're not the primary, maybe you're a secondary part of the medical home for an individual?
Yeah, so we first of all, we try to provide referrals to a primary care if they don't have one. A lot of times it's not just that you don't have one. It may that you do have one, but you don't have the ability to take off of work to follow through, or you may not be able to get to them. So it's either one of the two. With that being said, a lot of this is like a lot of health literacy too, right? So how did you get to the ER? Maybe your doctor, I don't know, gave you a regimen for your diabetes and you didn't fully understand like what that regimen meant, what those prescriptions meant, and that landed you into the ED here. So our goal when we see that patient at the door, whether it's inpatient, ER, is to really figure out like what's working for you, what's not, what gaps do you have, and we do have a strong social work case management team that will try to link you up with a primary care service. We do offer preventative services too, so we do a lot of, and I was really impressed. We do have a wellness calendar. We have a lot of preventative screenings, blood pressure, mental health that we offer throughout Chester County. We will come to you, making those resources and services available too. And then I'm really big on the bedside, really making sure that you understand that this is your treatment plan. And again, it may not be that you might have a PCP, but you just understand what they meant by this medication. So that's that health literacy piece. Or you didn't have the capacity to take the medication because, like Dr. Cook, I drive a bus, and for me to do this medication means I have to use the bathroom all the time. You have to really kind of dig away. And that digging away brings about opportunity and curiosity, and any one of us can do that. It's just our obligation and duty to try to figure that out when they're in front of you. So it definitely is compounding, but you got to take the time to figure out like what the problem is, where the gap is, and how you can best fill in that gap. And that's different for each patient.
I think your case management team at Chester County does a great job of contacting us with potential referrals as they're planning for the discharge. It's great that I can sort of start planning for that patient's care before they even get here. And I think patients are visibly relieved when they come with all their discharge paperwork and they're trying to make sense of it, and they present me with this whole binder of stuff, and I say, I already know. I read all about it. I talked to Dr. So-and-so. I know everything that happened. We made sure we were able to get this medication in stock for you. So let's talk about you.
And then we do have the ability to, like in our EHR system, to route things really easily. We do have care everywhere, so we can, if someone shows up into the ER to the floor, I can, for the most part, see like what their past visits look like, what's been missing, what's been done, because not everyone is able to fully communicate like to you what the problem is or what they need at times. So I think it's every part of us putting in our piece and trying to put that puzzle together, the whole, like all of our systems. So.
Thanks. I've got a question, and because you and I, at least, have had a lot of conversations about this in the past, I want to start with you, but I think everybody can speak to this. Some of the questions that we received in the registration include, could you share your approach to providing care that embraces and respects multicultural diversity? I mean, I would say even diversity broader than maybe multicultural. Sexual orientation is another one I know we have a lot of conversations with in the health equity space. Rural versus urban often have different components of this. And so could you just sort of begin this part of this conversation talking about how we think about really seeing that person in front of us and the complexity of who all they are and where they come from?
Yeah, absolutely. I think it's such an important topic. And, at Union Community Care, and I'm sure the same thing at CVIM, and I'm sure the same thing with Chester County Hospital, our approach is really one of cultural humility. So it's not just cultural competence. I've always really hated that term because I don't want to just be competent at something. If I'm just competent, you probably shouldn't let me do it. But when we think about cultural humility, it means that I understand, number one, that who I am, and I understand that every single person has culture. And I think back in the day, it was always just like people of color had a culture and everyone else had a nothing, or the dominant culture didn't have a culture. But we all have a culture, no matter what our background is. So it's really understanding and grounding yourself and knowing who you are, and then having a humility, a humble perspective to getting to know someone else, and assuming you don't know. Just because you met another person who looks like that person doesn't mean you know anything. And of course, at our organization, we very much take the Institute for Healthcare Improvement's guidance of starting the conversation with what matters to you. What matters to you? So not what I want to make sure you know, but you tell me what matters to you. So that way, if what matters to you is your sexual orientation and your health and your mental health, you tell us that. If what matters to you is your family of origin and how that's impacting your health today, you tell us that. So it really has a different perspective where I think the individual is at the center and not the institution or the hierarchy necessarily that you sometimes have in healthcare, where there's a big power difference, between someone who has decades and decades of education and someone who may not have graduated high school. So sometimes there can be this sense of like, I know everything, you know nothing, listen to me, I'm here to educate you. When in reality, we have to shift it and it has to be, equal power. And by saying what matters to you, I let you kind of drive the ship.
I think that can be such an invaluable opportunity. So it can be a challenge working with patients whose cultural background doesn't match your own, or whose primary language is different than your own. But I think it is such an opportunity to sort of level any perceived difference in power. And I often invite patients to educate me on. I'm not going to just tell you to adopt a Mediterranean diet to try to address your hypertension, diabetes, and cholesterol. Why don't you tell me what your diet is? And maybe we can make some adjustments to what you're already eating. There is such a cultural component to people's diets. I think that's so important. A famous quote from Dr. William Osler was that the secret in caring for the patient is in caring for the patient. And I think that's really what Elisa's getting at, is that I can provide high quality care in the sense that I can throw hypertension medication and blood pressure and diabetes medication at you all day long. But if you're not going to take it because it has some unwanted side effects, or you don't know why you need to take it, I really haven't delivered any high quality care at all.
It's a great point.
I agree. And I think that a lot of the cultural humility starts with just the environment. That depends on who are they seeing when they walk through the door? Is there anybody that they can relate to, even if they're not taking care of them? Is there anybody nearby that they can relate to? What does your wording look like in your waiting rooms? What does the pamphlets or education materials, what does that look like when I give that to them at discharge? So I think our everyday processes and how we do things also indicates our culture and willing to be open and willing to learn too.
I've told this story many times, but it always fits into this section where I had a primary care physician and I was in their office with my daughter, and I'm mixed race, black, white, and my daughters are me plus white mother, and they're pretty fair skinned. And the doctor asked me if this was my adopted or stepchild. There's no reason for that question. And it's a crazy question. And all you had to ask me was ask me about my children. Ask me about, how we think about family medical history, whatever the case may be that you need to get at. Don't make an assumption because the color of my skin and the color of my children's skin that they're not biologically my children. And I'm sure that doctor didn't have malice in that question. That doctor no longer cares for my family. Wasn't going to continue because that completely shredded any level of comfort I had with that doctor, as well as their competency and how are they treating us? What issues are they looking for? Are they looking for issues that they think they should be looking for, or are they issues that are actually what need to be looked for within the complexity of my multicultural family? I also want to just mention that when we think about this cultural dynamic, we also are in an area in Coatesville and the greater Coatesville area that includes some of my distant relatives. My white side is Mennonite and was historically conservative Mennonite. My grandparents were conservative Mennonite. And one of the issues with that community is around vaccinations. I don't know if you all are familiar. I'm sure you're familiar with the death of the child in Texas, measles. I read an article recently, and it was a conservative Mennonite family. And the mother said, having gone through this, that given the opportunity again, she still wouldn't vaccinate her child or her other 6 children because the other 6 lived. And we're doing some other non-traditional medicine that we believe is why the other 6 didn't get measles. And so how do we address some of these kinds of concerns? We also know, due to a lot of medical testing of Black communities earlier in the last century, there's a lot of distrust that is warranted in its origin, but not helpful in its implementation now as an individual. How do we bridge some of those concerns from medicine, medical community history, those elements of who was allowed in a hospital or not? Right? We've got Atkinson Center, who in Coatesville, whose history was a Black hospital because individuals weren't allowed to go and be treated in the white hospital. How do we address some of these historically rooted distrust elements in your particular practices today with these harder to reach populations?
I think it starts with relationships. I can quote you the data and the information about vaccines and public health and the impact on individuals as well as communities all day long. But if we don't have a relationship and we haven't built that trust, I don't think any of that really matters to you. And to your point, Kevin, I think that agenda setting is so important. I might think that the most important thing to address today is your recent heart attack. But if you're worried about where you're going to sleep tonight, or you're hungry and you don't know how you're going to feed your family today, none of that really matters. So I think you have to allow patients to take part in that agenda setting so that their needs, or what they perceive are their most important needs, are getting addressed today. And then they'll come back to you. And I think that was an important point that Elisa made, that you're so much more than a diagnosis or a medication that's on a piece of paper. And sometimes patients are surprised when I ask them, who do you live with? How far did you go in school? What kind of work do you do? Is it shift work? Do you work overnight? How many hours do you work in a row? Are your relationships strong and healthy and supportive? Do you have some challenges there? But all of that, I think, plays into the relationship building and me understanding the context in which I'm trying to deliver medical care and what's important to you. And I certainly want to give Elisa a chance to talk about the fantastic program that they've developed with Plain People, because I was really impressed when you told me about that earlier.
Yes, thank you. It is, we call it the Plain Healthy program, and it's from the way the community defines themselves, which is they refer to themselves as the Plain community, which is why we call our program Plain and Healthy. And it really was completely developed based on relationships and trust. It's a mobile vehicle, and now it's actually an exam room on wheels, and it stops at different homes in Eastern Lancaster County, goes into Southern York County now, and individuals define their own stops. So we stop at different homes that they've defined. And I can tell you that the rate of measles vaccine acceptance is above 90%. And that's not by accident. That is really relationship building, and it is listening to the concerns, to the degree possible, allaying concerns, and then the community deciding that that is what they want. So we very much, I believe, must meet this moment in healthcare. So 10 years ago, if Dr. Cook said something, Dr. J said something about what we should do, what we should take, we absolutely trust that it was correct, and that's what we did, right? They're the doctor. That is not the moment we're in today. And we can have a whole conversation about who's to blame and why that happened, but it's different. And folks who know nothing about science believe they know more about virology than someone who studied it for 16 years. Is that okay? I have no opinion on that. Is that what is? Yes. We have to meet the moment. And as we meet the moment, I think there's an opportunity for us to ask ourselves, where do we go now? Because we used to rely on the fact that our education and experience were enough. And it's not, it's different now. There's so many messages, and folks are unable to identify the signal from the noise. So I think Dr. J is absolutely right in terms of it's the relationship, it's the understanding, it's the deepening, it's the trust, and then it's the, hey, let's talk about measles vaccines for your kids. Let's go over the pros and cons, and ultimately you make the choice. And I just wanted to very quickly kind of identify, Kevin, when you talked about the history of the study and the abuse on Black and brown bodies, that those are facts. And We are not just living in a history situation anymore. Today, what's happening is that I'm being told as a woman of color that my color no longer matters, that it's DEI and it's being erased from reality. Whereas what I do know today is that research shows that myself as a woman of color, if I go to a healthcare provider and complain of pain, my pain will be considered as less important than if another woman comes and complains of pain. So that's facts. That's reality. And we're in a moment now that it's not just history, that we're being told that, nope, gone. That no longer exists. And even it has never existed. So as our history tries to get erased and our present moment tries to be changed, I think we as individual members of a community have to kind of link arms. And this is not political. It makes no difference whether you voted, who you voted for, whether you voted or not. Link arms and say that we as a community of people still see each other. I still see you. You still are here. You still exist. You still, in all your complexity of who you are still valuable. And we aren't going to kind of let the noise and what's happening on the outside change the fact that there are still differences. You can tell me I can't say disparities. I'm going to say differences. So we can use different words, but the facts and the reality of our human experience will not be silenced.
That's so important, Elisa, when you talk about the experience of a woman as a woman of color in the healthcare system. And I think there's a lot of data to show, multiple studies that show that people get better care from someone that looks like them. And whether that's because there's more trust and engagement on the part of the patient, or whether that's because the provider who comes from a similar cultural background is able to render more culturally competent or humble care. I'm not sure what the answer is, but we have to diversify the healthcare workforce. We need to do it. And I'm fortunate to work in a place where, as you say, Elisa, or I think maybe Tiffany made the point that someone has to look like you. It doesn't have to be your provider necessarily, but you have to feel that you belong in the space that you're in. And so there are times when I'm talking to a patient, maybe it's a mental health issue, and I'll say, you know what, let me grab someone who's a native speaker to help me with interpretation here, because I want to understand all the nuances of what you're saying. And I don't think my Spanish is proficient enough for that. But the side benefit of that is that I'm pulling someone into the room that looks like you, and you're going to feel more comfortable talking to me about what you're experiencing, because as whatever I do as a provider, we don't look the same. We're not from the same cultural background, and I can't pretend that that doesn't matter.
Absolutely. I was just going to add a piggyback on just one thing. It's so hard in healthcare because, right, there's different systems that have shown like, that have been racist. Through various systems, but healthcare has been such a prevalent part of this problem that really until like we as a system continue like to acknowledge that these things have happened, we are a root cause of these current inequities, and really stand at a steady state to say this is where we stand, that distrust is really going to always be there. So you feel like you kind of go like this, right? And there's never any real like acknowledgement and saying we're steadfast in this and these beliefs and so on. So we are a huge part of the problem. And I think that's why the barriers and gaps currently do exist. I think when you think you know it all and you keep reading and reading, there's like more studies and experiments that you find out about. And as a Black female in medicine, is very just disheartening. So it's hard to have people run to systems and places that have again and again disappointed certain marginalized and vulnerable communities.
Yeah, I think that one thing I heard really strongly there is about space making a different kind of comfort, which allows for then a better interaction. I also heard about pipeline. And so I want to actually, no one was prepared for this question. So hopefully you can rapid fire respond. But very briefly, what got you all into medicine? I recognize that I have three women, two women of color in front of me. Historically, those are underrepresented categories in medicine, whether it's administration or on the service provider side. And I'm curious to hear from you. How did you end up in this? In part because I do want to talk a little bit about youth care and how maybe that also shows up in how we're actually building new doctors 20 years in advance because of how you're showing up with them in the moment. But what got you to here? How did you get inspired to move into this kind of work?
I can go first. I actually just did a youth summit on Sunday morning. So I'm huge on pipelining and what that means to be visible and shown in everyday spaces. Because they're watching you. Children or adults too, but children and youth, they're watching how you respond to adversity, how you respond to microaggressions, trials, conflicts. So basically, I've been diabetic since I was 10. And I was like really, really sick. I was in ICU. Looking back, I was really sick. I didn't realize it back then, like resiliency, but I was in ICU for a week. So I was pretty sick. And I was fascinated at that point in time with just the idea of like going and broken and being fixed. So I knew at that time that I wanted to either do like nursing or possibly medicine. But it was really my dad. Like I didn't know. I was telling the kids on Sunday, I didn't have a Black physician to relate to. I didn't see like Black doctors walking down the hall. I definitely didn't have anybody in medicine in my family. So for me, it was really my parents putting that idea in my head that like, Tiffany, you can do this. Like you're smart enough where you can look over this fence until we tear it down, look over this fence. And like I said on Sunday, my family told me very on, like my mom always showed me very on the disparities that that were out there. I grew up right outside of Newark, so very much like Philadelphia, very much like Chicago, very much like Camden. And she would drive us like an hour away to look at the differences in the grocery stores, to look at the differences in the houses and playgrounds and play areas and green space. So she made it, we talk about disparities and like health equities, but very on my mom, like, this is 40 years ago, let it be known that these differences do exist. And this is what you're going to need as a Black female to be seen and be heard. And they made sure that I was in like summer programs. I had good advocates, thank God for that, a good village, summer programs. And that's what I try to do now. I try to just be visible and show up and do it in a sense that's relatable and down to earth and people can come to you. Because it is achievable if you have the right guidance very early on. It's not something you want to do in high school. They need to see you while they're young to, get familiar with science, not to be afraid of science, to be able to make mistakes, to have, not just mentors, but eventually sponsors, people sitting at tables, things like that. So that's how I got into medicine.
Janet?
I was waiting to see if Elisa was going to go. Yeah, I had something similar. Maybe I had sort of a health crisis as an adolescent, and I had everything that I needed. I was very fortunate to grow up in a middle class family. We had insurance, we had preventive health care. And I remember thinking to myself, even at that young age, if I hadn't had these resources, what would have happened to me? Where would I be? And I think maybe it's my job as the beneficiary of these resources to find a way to extend them to the people that don't have them. And so, I was always interested in medicine, but I think that was sort of my draw to underserved populations. And I think too, and maybe one of the things that's coming out of this measles crisis that we have, not that anyone would have wanted that, but is making sort of the mainstream population understand that caring for our entire community makes a difference for all of us, right? So if we could make vaccines more available, if we could gain the trust again of people and we could all get what we need, we would all be healthier. So even if for whatever reason you don't see a need to care for those who maybe don't have the resources that you do, it will come back to you. And so it's in your best interest to make sure that everyone has the care that you have enjoyed. That's what brought me to medicine and to care for populations like the one I care for now.
So I just want to take a moment and acknowledge and appreciate Dr. Cook and Dr. Giacoppano. Female physicians leading the way, caring for individuals and caring for communities. Amazing. I'm not a physician. I am not a clinician. My interest in public health and healthcare came because I grew up in a family that couldn't afford healthcare. And when we got sick, we went to a community health center in our community, and it was called Comprehensive Health Center. And it had a big, ginormous gate outside of it. It felt very much like going into prison, like when you went to go visit someone at prison, you had to go through the gate, you had to get scanned, all that kind of stuff. It was very much that experience. You had to stand in line at 6 a.m. If not, you weren't going to get in. And you went through a dehumanizing process. It was a dehumanizing process. And I was a little kid. And I remember just thinking, like, why does it have to be this way? Just because we're poor, why do we have to also be humiliated? And I kept on thinking, like, and my mom used to say, what do you want to do when you grow up? And I would say, I don't want to be poor. And she's like, well, that's not a job. You need to get a job. And I'm like, I don't care what I do. I just don't want to be poor, because I just associated that life was different. And so my mom, never graduated high school, neither did my parents. So she was a self-taught woman, the most smartest woman to this day I've ever met, the strongest as well. And so she decided to send me to a middle school and a high school that was in La Jolla, California, which is one of the wealthiest communities in the nation. And that was the first time I saw grass in real life. And I was like, people have grass? It was like insane. It was like having gold on your yard. And I, just like Dr. Cook, I realized this is not the way we live, is not the way everyone lives. And so I knew healthcare was what I was interested in. I knew public health was what I was interested in. And my first job in healthcare was working at the clinic I went to as a kid, the Comprehensive Health Center. And I worked there running an immunization clinic. And from there, just continued to get different jobs. And when I talk to young people and part of pipeline work, I always tell them, always be a doctor. If you are not suited to be a doctor, think about another healthcare career. If you don't like bodily fluids, think about administration. There's still a role for you to serve. Maybe it is in an administrative role. And that's really where I found my calling, is in administration. And ultimately, I found a calling towards leadership, because I think leadership is essential if we are going to change the trajectory of the health of our communities. So as a leader, my primary job is servant. And I always tell students, healthcare is a vast field. Be a doctor if you can. And if not, there are still places for you to serve in healthcare and for you to make a difference. And don't assume that there's only kind of one way to be able to be part of helping our communities be stronger and more resilient.
Thank you. I think stories are always really helpful for people to connect with. And for me, I'm now in public health. It's sort of funny. I'm a theater major and peace and conflict studies major. I have a master's in divinity, and none of this says public health, until I realized that a large part of what I've wanted to do for me is just to help people. Like I always say, I remember a conversation with my dad when I was like 15, and he was picking me up from the park playing basketball, and he's like, you're about to go into high school, and you can do what you want, you can be who you want to be, you can focus on this or that. It doesn't matter to your mother and I whether you're wealthy or you're poor. It doesn't matter to us whether you're known or unknown. The only thing that is going to be for us, what helps us to be proud of you is that you help people. And it worked to connect me, inspired me. And so I've done a variety of things. And then, I sort of backed into running a Meals on Wheels program because I needed a job, and I had restaurant experience and I had nonprofit experience. And there I realized that, the tagline they often use is more than a meal. And I realized how things that we see in one way actually often have a whole bunch of other components in them that we don't see. And so when we think about delivering meals to a home, we're not thinking about the fact that it's a safety check. We're not thinking about the fact that if you have volunteers who are equipped to understand that someone complaining about their feet who happen to be on a list, may actually have some sodium retention. All of a sudden you start to realize there's a broader swath of things that are available than just dropping off food for someone so that they don't starve that day. And, right now we're running a food as medicine program at the Alliance for Health Equity that we're piloting for new families and pregnant persons and new families, and thinking about food as medicine and trying to connect that, partnering with some of the other organizations in the community. I think that this idea of formation for people at an early age that we all just talked about from a professional, why we're in public health spaces, that was formed in each of us in some way in our youth, is a really important component that we're always keeping in mind. And so, I'm interested because I also heard a lot of barrier conversations. Elisa earlier talked about a word that she hates in cultural competency. For me, I hate the phrase resilient. We always talk about resilient communities. And I always ask, well, why do you have to be a resilient community? Because there's a barrier for you to overcome. So I'm much more interested in us figuring out how do we remove the barriers instead of praising people for getting over barriers that we didn't need to put in front of them in the first place. So I'm curious for you, how's your work not just addressing the sort of here and now and forward, but how are you also understanding the challenges of barriers coming in, and how are we addressing barriers so next generations aren't having to deal with the same circumstances that the current individuals that we're serving do? So really thinking about youth and barriers and service, and hopefully all of that ends up inspiring these folks who you're actually interacting with, that they may be the clinicians and the administrators in the next generation.
I can start here. I think that well, I know that in order to improve like outcomes and have everybody on an equal playing field with equal opportunities and thriving, you have to get rid of the inequities that's at the foundational level. So that is making sure that everyone has secure housing, safe housing. That is looking at how our criminal justice system is playing out through policies and practices. That is making sure that our educational systems are up to par and equitable. And it's also like a part of our world is healthcare. So and that requires us to work outside of our domains, right? I don't believe that medicine is just me giving out a prescription pad. I know that my job as a pediatrician and as an advocate is to work with getting people out there to vote and to believe in voting again, because that's going to affect who's in office and who's creating policies and practices for our reform system, things like that, other shackles and chains, right? I know that like working with our educational system and our leaders on how to provide a quality and equal access to resources is going to make a difference in the jobs they get and then the healthcare that they're available to get and where they live. So it's all kind of interplayed and it's all intertwined. And like our job as providers is definitely to work with different stakeholders and figuring out how do I, as a pediatrician, actually go to Harrisburg and work on some of these things. That's what I'm huge on, right? Because my job, again, is not just to see you in the ER, but to work on long-term generational things. For me to truly create change is one thing for me to pipeline and mentor, which I do, but I need to work on the other systems that are at fault and weak. So I do believe that our jobs go beyond our hospital systems, our current healthcare systems, and really into like next level big stuff. To make transformational and generational change.
I would agree with that wholeheartedly. God bless you for going to Harrisburg and getting involved in that side of things. I don't think I have the skill set for that. I'm looking on a smaller scale to try to do, diversifying the healthcare workforce and the next generation of compassionate caregivers that's going to be taking care of all of us as we age and taking care of our changing communities. So we've invited technical college, high school students to come on site and take a look at everything that we do, including dental, social work, counseling, medical care, nursing, medical assistant, front desk, dispensary technician, looking at all of those things and self-identify if they would be interested in a job study program. And I think that those students might never have thought of themselves as having a career in healthcare, maybe because they never saw anybody else that looked like them. But we have a center full of people that come from different backgrounds who are all working together towards this mission-driven sort of goal. So I think that's important. Again, it's on a much smaller scale than making change sort of at the policy level, but I think we do have to invest in the next generation of caregivers, and particularly with a dwindling primary care workforce and all of the challenges with private equity coming into play and looking for short-term profits and investing in highly specialized medicine. I think we have to do that.
I think your question is so big, Kevin. You know, how do we continue to break down barriers? I think for us right now, to be honest, it is not bending. That's what we do. This moment is so difficult for us and for many other people that are in the business to serve the undesirables right now in this environment. So individuals who are vulnerable, individuals of color, individuals who are newcomers to this country, individuals who rely on Medicaid, individuals who rely on Social Security, seniors who are vulnerable. And all of those people are in some way right now being erased. And so our our work is to simply not bend, is to not bend, to not break, and our existence is our resistance. And it is hard right now to look out too far. You know, we every single day we are facing an attack, and I think our challenge is to not give in to the hopelessness because it can look very hopeless. And we know that when we are feeling hopeless, when we are feeling sad, we can't act. We somewhat become paralyzed. And it's not so much fear. There is a level of fear, but there is our heart is you know, the heart of this work is being challenged. So that is where we are. That is the barrier we're going to break. Is we're going to break through, and we are going to find those who still believe that a human being, regardless of their sexual orientation, the color of their skin, where they came from, a being who is having a human existence deserves good, high quality healthcare. And that's the stand we're going to continue to take.
No, absolutely. I think that, I keep in my mind hearing this phrase, you erase, we retrace. And I think of from a visual image, I think of when you're at the beach and you try to write words in the sand and the water comes and washes it away. What do? You write it again. I'm going to keep writing. Kevin loves, every time I'm just going to keep doing it. And that tirelessness is going to be really important as our communities are under threat. I want to finish with a question from the group here, or from the registration. When you think about the future of Coatesville, what are your aspirations for the community? We can mix that a little bit here. We're short on time, but what are your aspirations, real briefly? Where do you hope that we can take community in Coatesville from a health perspective?
That's another big question, Kevin.
Yeah, and you're only allowed like 3 sentences.
Oh.
I see. I pray and I hope for transformational change that is trusted and centered around like patient and community feedback, so that no matter where we are in the future, that is patient centered and driven and what they need and how they see it, and we continuously like go back to them for a check-in to make sure that we're on the right page.
And I would say, being a newcomer to the Coatesville community, I've been impressed by the history, and I think of like Coatesville having like roots of steel. And so my hope for Coatesville is that the roots of steel lead to continued blooming of healing energy, and that we can humbly join that work that they are already doing and to expand access.
Oh, I love that image of roots of steel. That's great. I guess building on that, I think we focus so much on healthcare delivery and all of the things that we can do, but I think we forget that patients have agency, and if you just create the opportunity, they don't always need that much from you. They really do have agency, and it's incredible what people are able to do. Even newcomers to this country who manage to get their kids in school, raise their families, put food on the table, make it to a job. I mean, I don't know that they need so much from us other than just opportunity. So I think that's my goal for Coatesville. I would love to create an opportunity for people to come into healthcare from the preventive side. It's so difficult to get a hospital discharge who had never had medical care, and now they've got 4 chronic medical conditions, when some of that could have been avoided if we only could have made an opportunity for preventive healthcare available to them sooner.
Well, thank you all. Thank you, panelists. Thank you, participant or for audience members for participating here this afternoon or late morning. Really appreciate those of you who are listening and catching this in later. Again, thank you to Dr. Janet Jacoparo. Thank you to Dr. Tiffany Cook, and thank you to Elisa Jones. Look up each of them, look up their work, look up their organizations. Be glad for anybody to make financial contributions to this work. Really grateful for anybody who can find volunteer time or other ways of participating. I'll say for me, my aspiration for the Coatesville community is the fact that too often disinherited, and that's a term I intentionally use, disinherited communities that built the wealth of a community that was then extracted, too often they then begin to feel that they are only worth what has been left for them, and that is not true. So my aspiration for the Coatesville community is that it realizes it deserves more than, in some cases, it's been allowed to even dream towards, and that we can build those dreams and then we can build those realities, and we can do it together in a way that doesn't leave people behind and doesn't build anew so that it can be extracted in the future and leave people behind again. And so I hope that we can continue to build together, build better, and make sure that everybody has at the top level of what anyone should ever deserve. Thank you all so much for your time. We will catch you again next time. Take care.
Thank you.
Bye.
Thank you, guys.